streaming and yes, and then we will start at 7 and then you can start the recording.
Yes, sir.
Yes. Who is it? Himanshi?
हेमांशी बेन लीव पे है सर.
Okay. Okay, we can start recording.
Yes, sir.
Tell me when you are ready, when you have started recording, I'll start then. Good evening, everyone, and welcome to the second part of the 21st Masterclass of Jaipur Surgical Tutorial on liver resection. For those of you who are attending or who would be watching this video for the first time, a brief introduction about Jaipur Surgical Tutorial. JST, as we call it, is an online education portal that we started 4 years ago in April 2021 when I moved from SGPGI Lucknow to Mahatma Gandhi Medical College and Hospital in Jaipur. And this is being managed by my colleague, Dr. Anand Nagar, who is a professor of HPB surgery and liver transplant at my institution, the Mahatma Gandhi Medical College and Hospital in Jaipur. In JST, we conduct an online academic activity every Saturday morning, 9 to 10 a.m. India time, where students, mainly MCH and DNB students in GI surgery and HPB, they present cases as they would do in an exam, and the case is then discussed by the faculty. Sometimes students also present an operative procedure, indications, contraindications, preparation technique, and complications. And again, the session is moderated by faculty. And once in a while, we have guest lectures by faculty, especially on related topics like anesthesia, radiology, radiotherapy, oncology, and other topics. Sometime last year, we started the JST masterclasses, which are held on last Wednesday and Thursday of the month, 7 to 9 p.m. India time again. And this is a single theme online educational activity in which we pick up a topic and we collect a panel of about 6 to 8 experts, some of them present, and 2 senior people moderate. And yesterday, for the first time, we had a JST student as a speaker, Mrunal Avalekar. She's a third-year MCH student at Amrita in Kochi. And when I had placed the request on the JST group, she volunteered and she made a very good presentation. So I request all the students also that if you would like to present in a topic or a subtopic in one of the future masterclasses, please contact me, message me, and we will then make you a speaker. In between, I will project a slide which will show you how, if you are already not a member of JST, you can join JST. It's a totally free, complimentary educational portal. And after each class, students who want, I provide them complimentary copies of chapters from my books on clinical surgery and operative surgery related to the topic which was discussed as a case or in the master class. So we had the first part of liver resection masterclass yesterday, and today we are going to have the second part. And to moderate this session, I have the pleasure to introduce my former fellow from SGPGI and now a senior consultant GI, HPB and liver transplant surgeon at AIIMS in Hyderabad, Dr. Phani Krishna Ravula, and he will be moderating the session. The speakers for today are Dr. Krishna Gurana, who again is a fellow from SGPGI in Lucknow, and currently he is an assistant professor at the CMC Vellore. We also have Dr. B.D. Pattnaik, Dr. Brahmdat Pattnaik, who's an assistant professor of surgical gastroenterology at AIIMS in Bhubneshwar. And we will be joined by Dr. Ganesh Nimje, who's currently an assistant professor in anesthesiology at AIIMS Gorakhpur, but he was my former colleague at Mahatma Gandhi Medical College and Hospital till about a year ago. And in fact, he was one of the pillars of our liver transplant program. He will be joining us shortly. So with that brief introduction of the JST and the master classes and the speakers, I hand over to Dr. Phani Krishna to make some introductory remarks about liver resection for the benefit of students, and then ask Krishna to start his presentation. Phani, over to you.
Awesome. Yeah, I think today it's a topic covering really the basics of liver resection, mainly I would say the hemostasis part. There are the gates of entry, the inflow control, and the related Pringles, and probably hopefully we'll talk about more selective vascular occlusions also, and also TEG. It's an important part of the complex mapping the complex liver coagulation profile in the course of surgery. So without further ado, I would request Dr. Krishna Rao Gurana from CMC Vellore to take up the first topic, gates of entry into the liver.
Good evening, all. First of all, I would thank Kapoor sir for giving me this opportunity, and I would also thank Dr. Phani sir for moderating this session. Greetings from our Department of HPV Surgery, CMC Vellore. So here I am here to talk regarding gates of entry into liver.
Yes.
So overview, we shall just have a look at the anatomy, approaches into the liver parenchyma. We will predominantly discuss about the Gleasonian approaches, and then we will go into gates and landmarks. There are some inflow landmarks and outflow landmarks, and some discussion on the techniques. So the anatomy, what we see is the picture on the left side, very clear, the right lobe and left lobe, and then falciform ligament. But the interior of the liver is very complex. There are so many vessels, arteries, and segmentations. See, we can see here the middle hepatic vein will divide the right lobe, will divide the right and the left lobes. The right hepatic vein will divide the right posterior and right anterior, and the left hepatic vein will be in the in the segments 2, dividing the segment 3 and 4, and we have an inflows, the Gleasonian pedicle. So the interior of the anatomy, interior of the liver is complex. So we need to have some landmarks, how to approach, how to enter into this complex anatomy, so that we can do a safe liver resection. So this is the inferior part of the liver, where we can see the plate system. So this is the cystic plate, this is the hilar plate, and this is the umbilical plate, and this is the arrhenius ligament, or the ligamentum venosum. So coming to the nomenclature, yesterday there was a discussion regarding the nomenclature. If the liver segment, the liver is divided into so many segments, 2, 3, 4, 5, 8, and 6 and 7. So we know that the 5 and 8 is the right anterior, 6 and 7 are the right posterior, segment 2, 3 is the left lateral, and 4 predominantly is the medial, left medial. So the segmentation, there is a concept of craniocaudal segmentation, where we can see that the superior segments at every sector is divided into superior and inferior segment. But there is also a concept of longitudinal division, wherein the sector is divided into ventral and dorsal. So coming to the approaches, predominantly there are intrafacial approaches and extrafacial approaches. Intrafacial
Yeah, it's okay. We can see. I think he lost the connection. We'll wait for some time.
Yes.
Funny, yesterday we were discussing the anatomy, and then the new world terminology by Nagino was also introduced. So while Krishna is getting connected, maybe you can make a comment.
Yeah, I'm not really aware of the new terminologies. Maybe you could talk more. I'm not really sure which classification you're talking
So,
about.
any comments on the Brisbane classification? Any problems which you think we have with the Brisbane? What I commented yesterday was that this terminology of lobe, sector, and segment, there are issues because conventionally we call caudate lobe as a lobe, but it is a segment. And then on the left side, we call segment 4 as the left medial sector, but it is a segment. And left lateral segment, we say, but it is not one segment, it is two segments. So that was my comment. And third, a common mistake which students say or write is that the left hepatic vein is the boundary between 4 on one side and 2 and 3 on the other side, which is not true. It is actually a boundary between 2 and 3. Okay, Krishna is back. I think we can allow him to continue. Krishna, please.
Yes, sir. I'm unable to share my screen, sir.
Yes, yes. Dwarika team, please make Dr. Krishna a host again and make Dr. Pattnaik also a co-host because he will be the next.
Either that or if there's not much of video in this, are there a lot of video in this, Krishna? If not, you could just mail it to the Dwarika team.
We test played. Okay. There was a video which was easily played. Dwarika team, please make Dr. Krishna also a co-host. Yes, Krishna, now you can share. And while he is coming up, I can inform that yesterday's session already has 400 plus views in 24 hours. So, yeah, please carry on.
I am unable to. I'm unable to share the screen, sir.
But we can see it.
We can see it.
Yes, yes, we are seeing. Only thing is go to the full screen mode, slideshow.
Sir, actually,
sometimes this problem comes that the presenter is not able to go to the full screen mode. Maybe you can continue like this. Only thing is that you will have to change the slide from the panel on the left.
Sir, I will just log out and log in again, sir. I am not able to.
Okay. Yeah, so we will continue that discussion.
Yes, sir.
Nagino's classification is actually an alphanumeric kind of a classification where they have used the terms H, S, and one more term they used.
And
it's a very complicated classification. I don't know whether it will find acceptance.
The Japanese are generally make things complicated.
It definitely is more accurate.
Only in the left side, there is obviously the confusion that the segment 3 and 4 actually make the left medial sector. That's something where traditionally, they're all going wrong.
Yeah, if we take the vein as the demarcation line between the two sectors, then you are right that left hepatic vein separates segment 2 from 3 and 4 combined.
Yeah.
So that is why I think best is to describe that what all segments have been removed.
Yes, sir, can I share?
Are involved.
Yeah, please, Krishna.
Sorry.
Yeah, that's okay.
Dwarika team, you will have to make Dr. Krishna a co-host again because he has logged in again.
So the Nagino classification, so pardon my ignorance, is it like related to the pure anatomical description or it's like the hepatic mean in relevance to your resections?
The new classification?
The new classification.
It is basically anatomy, but more applicable to
the liver resections, what you're resecting.
Dwarika team, please make Dr. Krishna a co-host again. Yes, now. Krishna, you can share now.
So here in this picture we are able to see.
Yes, we can see your slide with 4 images.
Yes, sir. So
Yes.
in this picture we are this is a intrafacial approach wherein we are like I individually like individually identifying separating the structures in the Glisonian pedicle and separate and ligating them. And in this, after a liver resection, we are looping the Glisonian pedicle. And in this, without any liver resection, we are just trying to loop the Glisonian pedicle. So these both are Glisonian pedicles. This is extrahepatic. This is intrahepatic. This is extrahepatic. So the biggest advantages with Glisonian approach is there is lower risk of vessel or bile duct injuries, and they have a safe and they are safe and feasible even for major and challenging procedures. And the biggest disadvantage with them is they may not be used when the tumors are close to the hilum, and they may be challenging in repeated hepatectomies. So coming to the gates and doors. So we all know that the interior of the liver is so complex. We need to have some gates and doors to enter into the liver and properly do our liver resection and come back. So what are these gates? So these gates and doors are landmarks to identify boundaries. They may be native and sometimes we may be creating them. They may be intrahepatic and extrahepatic. So these actually determine the intersegmental or sectional planes. So those are roots of the Glisonian pedicle, landmark veins, which can be these both Glisonian pedicle and landmark veins can be both intrahepatic and extrahepatic, and the demarcation lines. The demarcation lines are usually extrahepatic and mostly they are created. So coming to the first Glisonian pedicle approach, it was first described by Takasaki et al. So he has divided the liver into 3 segments: the right, middle, and the left segment based on the 3 secondary pedicles. So and the intersectant planes, he has identified right hepatic vein and middle hepatic vein as the intersegmental planes. So, if we will be able to loop any of these structure, any of these Glisonian pedicle, we can give a demarcation line. We can have a demarcation line, and we can safely do a liver resection. So, with this technique, resection of any one of the 3 segments is possible. Cut the corresponding segmental branch of the Glisonian pedicle. Dissect the liver in the intersegmental plane. So here, if we wanted to remove the middle segment or the right anterior sector, we should loop this Glisonian pedicle, and we will get the landmarks, and we'll try to identify the intersectoral planes. So for these, these are very crude. They don't have very proper landmarks, or there is no standardized procedure. He says we should have a small hepatotomy above the hilum, and we should try to identify the bifurcation of the right Glisonian pedicle into right anterior, right posterior, and we should have one more hepatotomy here and try to loop whichever segment we wanted to resect. So this is for the this is for the middle segment, this is for the right segment, and this is for the left segment. He also given a concept. He also gave a concept of cone unit resections, wherein if along the any sector, if along the any sector, any secondary pedicle, there are multiple tertiary pedicles. So each tertiary pedicle will supply to one cone unit. So apparently the coinode segment, one coinode segment may have 2 or 3 tertiary segments. It means that one coinode segment is a cluster of 2 to 3 cone units. So if we go along one of the pedicles, we can ligate these pedicles and try to have the demarcation line, and we can resect the respective cone units. So the main pitfalls that we have already discussed, there is no standardization and there is an inevitable damage to the liver. So now the concept, the new concept of liver capsules of liver has come. We identified that there is a capsule called Linek capsule, which covers the whole of the liver. It is described first in 1802, but Sugioka et al. In 2017, they have identified some areas wherein we can standardize this approach to the Glisonian pedicles. So if we see here, the Linek capsule is the one which is covering the whole of the segment, the whole of the liver, the bare area, even the Glisonian pedicles intrahepatically, and even the intrahepatic venous system. So there are some gaps between this Linek capsule and the Glisonian pedicle, which can be helped in standardization of this extrahepatic Glisonian pedicle approach. So to identify that, there are 4 landmarks: the cystic plate, the arancious plate, the umbilical plate, and the chordate process pedicle. So we are talking about these gaps. The red color is the Linek capsule, and this is yellow color is the Glisonian pedicle. And these are the black color is the gaps, which they call the gates. So these gates can be entered without any parenchymal damage. So there are 6 gates. The first gate is at the arancious ligament. The second gate is at the umbilical, at the round insertion of the round ligament, and the third gate is at the right edge of the Glisonian pedicle, and the fourth is at the left edge of the anterior Glisonian pedicle, and the Ruvius sulcus, anterior to the Ruvius sulcus is the 5th gate, and posterior to the Ruvius sulcus is the 6th gate. So we can find that there is some spaces in between, wherein if we try to connect one gate to the other gate, we will be able to identify a sector or a section or a section, and we will or a lobe, which will help in giving demarcation line and helping in proper liver resection. So in this image, we will be able to see this is the Glisonian pedicle, and this is the Linek capsule. So whenever we divide the serosa, we will be able to enter into this space and try to loop the Glisonian pedicle safely. So for left lateral sectionectomy, if we connect the gate 1 and 2, we will be able to secure this the inflow control of this segment 2 and 3. So at the like the same way, if we connect the gate 3 and 1, we will be having the inflow control of the left lobe. So the same way, if we connect gate 4 and 5, we will be able to secure the right anterior sector, and we will be to secure the inflow of the right posterior sector, we should connect gates 5 and 6. Coming to the segmental or subsegmental dissections, still there are no landmarks for segmental and subsegmental dissections. Even the Brisbane the nomenclature also doesn't really give specific landmarks how to define a segment. So sometimes maybe we should be able to create some landmarks using subtraction techniques, or and this is all possible when we identify one pedicle and dissect along those pedicles and try to loop every tertiary segment separately and get the demarcation line. So for segmental and subsegmental dissections, we should know the branching anatomy of the pedicles. So the complexity is more on the right anterior and right posterior pedicle system. So the ramification system of the right anterior sector is always the main trunk of the right anterior pedicle will go continue as a superior pedicle, supplying the upper part of the right anterior section, that is the segment 8, and these are anterior and these are thick walled and they are very well formed. So the segment 8 pedicles are usually downwards and they are very thin and they are multiple. So we will be able to see here. These are the segment 8 pedicles, and these are the segment. These are the segment 8 pedicles. These are the segment 5 pedicles. So in the right posterior sector, the segment 8, the pedicle which is supplying the segment 8 is the one which is going, which takes like an arc like thing in most of the cases, and multiple segment 6 pedicles will be branching from this arch of the main segment 7 pedicle. So in order to have a segmentectomy or a subsegmentectomy, we should try to negotiate along, we should try to dissect along the pedicle and ligate or loop and clamp individually all these tertiary pedicles to have the demarcation line. So these are the internal, we have some more external landmarks. Other the Ruvius sulcus, which is very common landmark, which will help in the right posterior sectionectomy. So just looping the Ruvius sulcus, we will be able to loop the pedicle to the right posterior sector, which will give the demarcation line to the right posterior sector. So if at all we wanted to do a right segment 6 resection, first we will try to loop the Ruvius sulcus. We will get a demarcation line, and after doing a small hepatotomy, we will be able to. So this demarcation line will separate the right posterior sector from the liver, from the main liver. But after a small hepatotomy in the inferior side, we will be able to identify the segment 6 pedicle. So after identifying and clipping the segment 6 pedicle, we will be able to separate the segment 6 from the segment 7. That is how an isolated segment 6 resection is possible. So the next external landmark is the umbilical fissure. This is an external landmark which will have an umbilical fissural vein in most of the times. So this will divide the left lobe into segment 2, 3 and segment 4. So dissection along this Grisonian pedicle, if we want to isolate and isolation of segment 2 and segment 3 pedicles is possible, which will help in segmentectomy and sectionectomies. So coming to the next landmark is the ligamentum venosum. So encircling the left Grisonian pedicle ventral to the ligament. In this picture, we can see that this is the ligamentum venosum. So if we wanted to safely encircle the left lobe Grisonian pedicle, it is always better to encircle above the ligamentum venosum, which will help and divide the pedicle as caudally towards the venous, towards the on the ligamentum venosum, so that if there is any biliary and abnormal biliary anatomy. So most commonly we are more worried of a right anterior sector joining the left duct or right posterior sector, biliary duct joining the left duct. So if we try to divide the Grisonian pedicle somewhere above the level of the ligamentum venosum, we will be able to safely avoid a bile duct injury of the right aberrant duct. So now with the external landmarks, we will have some internal landmarks. These are mostly we should create them. One of the landmarks is the anterior fissure vein. So this landmark you can be able to create. It is a fissure midway between the right hepatic vein and the middle hepatic vein. This is the right hepatic vein and the middle hepatic vein. So to do that, first we should try to ligate. We should loop the right pedicle and have a demarcation line to identify the middle hepatic vein fissure, and then we will identify the right posterior sector and ligate it, so that we will get the demarcation line of the line of the right intersectional plane between the right anterior and right posterior. Now in between this midway in between this, if we do a hippototomy, then we will be able to trace the right anterior sector along this. So this is called the anterior fissure. So whenever we wanted to remove ventral segments, ventral anterior sector, anterior segments or dorsal segments, we can try to loop these pedicles in this manner. So here we will see that the anterior fissural vein will be there here. So if we want to remove these segments of the liver, we can ligate these tertiary pedicles and remove this segment. This is what we can see in this picture. So if we wanted to remove a right ventral portion, we can ligate these pedicles. And if we want to remove the dorsal pedicles, we can dorsal part, we can remove the ligate these pedicles and get a demarcation line. So coming to hepatic venous guided approaches, we know that the Linac capsule is all around the hepatic veins also. So this is the hepatic Linac capsule. Even on the hepatic veins, there is a Linac capsule which is derived from the diaphragm and the pericardium. So there are gates in between the Linac capsule and the hepatic veins also. So the advantages of hepatic vein guided approaches is the liver is shallow here and it is easy to expose the hepatic veins at the roots. And there are few branches and they are thick walled and all. So these approaches will always involve a small liver resection and they are usually transfissural Grisonian approaches. So the hepatic venous approaches are of two types: outer Glisonian approach and interlinear capsule approach. So this approach, the advantage of this approach is you leave one of the linear capsule with the hepatic vein, which will avoid injury to the hepatic veins. And the advantage of this is whenever there is an extra paracaval tumors or dextracaval tumors, so dissecting the linear capsule of the liver will give a surgical margin. So whenever there is a tumor and we are worried of a surgical margin, it is better to go in the interlinear capsule gates. So the most problematic segments to be dissected are the segment anterosuperior segments, as we all know, because they don't have any proper landmarks. So there are some techniques wherein we can this hepatic venous guided approaches are most useful in the resection of these anterosuperior segments. So we can identify the right hepatic vein by an intraoperative ultrasound, or we will clamp the right posterior pedicle to identify the right hepatic vein plane. Then we have two options of opening the paracaval portion of the caudate and the segment 8, and to identify the pedicle of the segment 7, or we will also loop the right Glisonian pedicle to identify the middle hepatic vein fissure. So by this we will have if we go into the middle hepatic vein fissure, we all know that these hepatic vein fissures, the Glisonian pedicles will never cross this. So whenever we identify the middle hepatic vein and try to dissect along the vein, we will find the pedicles to the segment 8. And ligating the pedicle of the segment 8 will give the demarcation line of the segment 8, and then the rest of the resection can be continued based on this demarcation line. So coming to the hanging minervas, they are actually roads during transections. They connect the inflow and the outflow, and they are most useful in controlling bleeding, maintain correct anatomical transection planes, and protect the IVC. So there are so many techniques of hanging minervas for using one tape, single tape, and multiple tapes, depending upon what section we wanted to remove. According to that, we have multiple techniques of hanging minervas. So usually for lift hip hanging minervas are not needed. But if at all we wanted to use hanging maneuver for the left hepatic, it is always better to loop, to have the tape above the ligamentum venosum, so that the chordate pedicles will not be injured during transection for a left hepatectomy. So during transection for this hepatic venous guided approaches, so we should always expose the veins from the root to the periphery, and we should always try to avoid a split injury, because the split injury may extend onto the cava. And so lastly, if you know how to go and where to go, gates really do not matter. So take home message is precise anatomical planning is the key to safe liver resection. Preoperative imaging. Understand the anatomy of the patient and the anatomy of the disease. And ICG staining techniques can also be used in having these demarcation lines. So thank you all. I have a small video on how to showing these gates.
Yeah, please go ahead. Krishna, you can keep describing.
Sir?
Hey, I can talking about it, but so that we understand what's going on there.
So this is the round ligament, and this is the umbilical fissure. So actually what we are trying to see is, this is the arrhenius plate, and the gate 1 will be somewhere here. And the second gate will be attachment of the umbilical fissure and the round ligament. So if we connect the gate 2 with the gate 1, we actually will be trying to control of the segment 2-3. So the gate 3 is usually on the right of this attachment. This is the gate 3 and the hilar plate. So if we connect this one, so if we connect the gate 3 to the gate 1, then we will be able to get a control of the right pedicle completely. So now we are able to see, this is the hilar plate, and this is the border of the anterior border of the anterior glissonian pedicle. So this is actually the station, the gate 4, and this is the posterior pedicle. We are able to see the posterior pedicle here. So the gate 5 is here. So if we will be able to connect the gate 5 and gate 4, actually we are controlling the anterior sector glissonian pedicle. And so this is the gate 5. So now the gate 5 and gate 6. Gate 6 is just proximal to the caudate process pedicle. Somewhere here we can see the caudate process pedicle. So this is gate 6. So whenever you connect gate 5 and gate 6, actually we will have a control of the right posterior pedicle, and we can have a demarcation for the right posterior section, or identifying the plane where the right hepatic vein can be identified. Thank you.
Okay. Thank you, Krishna. Phani, your comments about these gates and basically to the young surgeons and students, that how they should use these gates for doing various types of liver resections.
So I think, briefly, where do we use what he described was basically we have two ways of controlling the inflow of the liver. To simplify it, it's an intrafiscial approach and an extrafiscial approach. So intrafiscial approach, with dissecting the individual artery vein, we use in, let's say, high local angiocarcinoma, gallbladder cancer, biliary malignancies. and of course in living donor. In these areas, in liver transplant and biliary malignancies, there's no role for extrafacial approach. Extrafacial approach is in practice. We use at least in the Indian surgeon's perspective, we mainly use for central hepatectomies, in which we take the segment 4 pedicles and the right anterior pedicle. We use for left lateral segmentectomies and right posterior sectionectomies. I mean, this is actually over the years, in 20 years of practice, this is where I've been using the intrafacial, extrafacial approach. And so in these three areas, it's because it's fairly easy to approach these areas. The segmental approaches, I mean, again, we keep going to the conferences. The Japanese surgeons, they're very meticulous about mapping out each individual segment and doing a segmentectomy. But honestly, if you look at the literature for a small size HCC or a colorectal met, there is no data showing that anatomical resection is oncologically better than a non-anatomical resection. So I think most of the time, except if it's in the left lateral segment, we are not really going for individual segmentectomies much. So these three areas where we're using. And one thing is, the traditional books, the old books, they keep talking about hepatotomy and blindly passing your right angle across and coming out. That is still a relevant approach, but we in nowadays, when we actually do the extrafacial dissection, the CUSA is a much better way of, because the Glisonian fascia, the fascia is very tough. So you can actually skim over it with your CUSA and go around much more safely, because if you try to do it blindly, and especially we're not very experienced, again, all of us don't do it routinely, you can poke into the liver and damage the intrahepatic veins, and they can start bleeding. So the CUSA can be a good way. And if you ask me practically, so in the extrafacial approaches, one is the totally extrahepatic approach, and one is during the hepatotomy, during the liver transection, and then taking the Glisonian pedicle there. In some areas, so let's say the three areas which we commonly do, like I said, is central hepatectomy, left lateral segmentectomy, segment 4B5, right posterior sectionectomy. For the left-sided pedicles, the whole left pedicle, the segment 2, segment 3 pedicles, the segment 4 pedicles, it's very easy to, actually, if you go to the umbilical fissure, even do a brief hepatotomy in the superficial parenchyma, you're going to easily identify those pedicles. And you can take them extrahepatic, or when you're transecting the parenchyma with CUSA, you can take them. On the right side, the right posterior, like Krishna said, that it's the Ruvius sulcus is there as a good marker. And the right anterior, the plane anterior to the, between the Ruvius and to the left of the cystic plate, to do that blind requires a lot of guts, because you're never really sure of the anatomy. And that's when, especially this pedicle, the right anterior pedicle, it's better to take the transparenchymal approach. Let's say we're doing a central hepatectomy. How we would do is, we would, the left-sided transection plane, the segment 4, like I said, it's very easy to ligate them. You can do them extrahepatic or intrahepatic, the Glisonian pedicles. But the right-sided, normally we would identify the right hepatic vein, map the right hepatic vein. And as we transect, we will come across with your CUSA, you go on to the Glisonian pedicle, and then you can easily identify the right anterior safely and avoid injuring the left. Yeah, that's the way we do it, and I think that's how most of Indian surgeons practice it. The segmental level, I don't really have much of experience. Krishna, I had one question for you. You were talking about the Glisonian, the Lennox capsule on the hepatic veins. But when we do the transection, the toughness which we find of the when we're dissecting around the the Glisonian, the tough sheath, we never see on the hepatic veins. So is it something which we will be able to identify when we come from the root towards the periphery? When we go onwards onto the roots, is it something we would always miss? I just wanted some clarity about that.
This is best seen. Usually, these are best described for laparoscopic surgeries, and maybe the magnification is what which will really help in identifying these gates better in a laparoscopic view. So usually these the space between the hepatic Lennox capsule and the Lennox capsule, which is associated with the hepatic veins, there is some space which can be entered safely. That is what.
Yeah. No, even like when we're doing the actual regular parenchymal transaction, once we identify the main trunk of the vein, obviously transaction becomes much more bloodless, and that is true. And a very important point you made is the gating, I mean, which we were not using much. Now again, we are back to more of laparoscopic and robotic surgery. It's much more relevant now. Exactly, that's a good point.
So before we move on to Dr. Pattnaik, just two questions, Phani. The hepatic venous approach, which Krishna described, is it frequently used by many surgeons, or it's more?
No, I don't think. I mean, at least I've not seen it. In
Yeah.
fact, first time I'm hearing about it. Obviously, I'm sure it is a technique. And the traditional diagrams also show the Linux capsule extending along the hepatic veins, but we don't use it. But that philosophy of tracing the hepatic vein route and going towards the periphery, it's a very useful tip in doing liver resections, because even when we are trying to go doing the donor and all that, sometimes when we go to the root, because the veins are much thicker there, the branches are thicker, it's more easy to identify and can come back that way.
And second, from students' point of view, the division of the right pedicle into anterior and posterior sector almost always will be extrahepatic.
No, it's highly variable. So I think we were more often than not, as a Glisonian pedicle, you can't sling the right anterior pedicle extrahepatically. You'll have to do it transparenchymal through hepatotomy only. And once you see all the variations of the right anterior pedicle, which some of which Krishna described, the right anterior pedicle, unless you're doing it regularly, it's better to do a hepatotomy, identify it, be sure, and then divide it. It's difficult to do the right anterior Glisonian approach extrahepatically, except in some selected cases, very rarely. More often, it will be intrahepatic. What do you say, Krishna?
I think he lost the connection again, because Dr. Miyazaki for gallbladder cancer has described that to see the line of demarcation between segment 5 and segment 6, you can clamp the right posterior pedicle and that will demarcate.
Yes,
so
yes,
it's a temporary clamping from that point of view.
Yeah, absolutely. So that and mapping the right hepatic vein is also why, but this is more accurate, because mapping the right hepatic vein in a 3D, you can't get the exact this thing, but that's a good idea.
I think we will move on. So next speaker, as I mentioned earlier, is Dr. Brahmdat Pattnaik, who is a faculty member in surgical gastroenterology at AIIMS Bhubneshwar. And he's going to talk to us about Pringle, which is a very useful, at the same time, very debatable topic during liver resection. Over to you, Pattnaik.
Good evening, sir, and good evening, Phani sir, as well.
Hi.
So, really fortunate that I've been given this opportunity in this very well-known academic forum. So, I'll directly start sharing my screen. Yes. Is it visible, sir?
It's coming. It is coming. Still, yes.
So,
yeah, we can see.
Good evening, everyone. So, today I'll be speaking about the inflow occlusion methods, and obviously I'll touch upon more about the Pringles, but obviously I'll speak about other ways of targeting and isolating the inflows, as well as in one or two videos I'll try to show how to control the outflows as well, and in what scenario we should be controlling this. So I'll try to describe my talk on this following 5 headings, and gradually at the end I'll try to share some of our experience of different case scenarios. So Pringle himself first published about the method in Annals of Surgery way back in 1908, and when the first patient died in the OR after a liver injury, he went back and he thought about how he could have controlled the bleed intraoperatively. And in the second patient, he just used his thumb and the index finger and he tried to control the bleed in the next patient, and and surprisingly he found that all the bleeding from the liver and parenchymal surface, it stopped. But the second patient also died, but at least he could gain that by controlling the hepatoduodenal ligament. He could control the bleed at least. And then he went back to the animal experiments and applied the same methods in 4 of the rabbits. And then he again came back to the OR table, and then he controlled the third or fourth patient. The first 7 or 8 patients, they died subsequently, some on the OR and some in the post-operative period. But within a year or so, he gradually learned that in women's, there are so many naturally occurring portosystemic collaterals. And if at all he is clamping the inflow vessels continuously also, then also there is not much of a mesenteric congestion in contrast to other animals. So that laid the foundation stone of this all kinds of inflow occlusion, from which hundreds of surgeons got benefited, and it translated to saving so many lives as well. And obviously, it started with Pringle, and then it went on to hemihepatic occlusion and isolated segmental vascular occlusion as well. So, as a hepatobiliary surgeon, we must know about the physiology of clamping. Whenever we are clamping the inflow, specifically the portal vein, then as we know, the portal vein is a major supplies major chunk of the blood to the liver, closely to 60 to 70% of the liver blood flow is supplied to the portal vein. So once we are clamping the inflow, there is lack of oxygen and substrates, which gradually leads on to anaerobic glycolysis. And as we know, whenever there is anaerobic glycolysis, there is increased lactate production, which leads on to metabolic acidosis. And whenever there is metabolic acidosis, the type of cellular injury is always a necrosis. It mostly results from the bursting of the individual cells, and there is cell death. And this is how we get too much of transaminitis after clamping. Suppose we are using any type of clamping in the post-operative period, specifically the AST is more specific for the liver. So the amount of cell lysis which occurs by necrosis, that decides your post-operative transaminitis levels. And when we declamp, then also there is an injury. It is called as a reperfusion injury. Once you are reperfusing, that is, you are releasing the clamps, then also once there is restoration of the oxygen supply, there would be reactive oxygen species generation immediately, followed by the inflammation later on, maybe 6 to 8 hours later. And both these processes, they paradoxically enhances the damage. And the type of cell death out of this reperfusion, specifically related to reactive oxygen species, is a apoptosis. So in ischemia, the type of injury was necrosis, and after declamping, the type of injury is apoptosis. And this ischemia injury plus reperfusion injury, it always increases with the amount of with the severity of the liver resection. So there are so many strategies described to prevent this IR injury for liver resections, and more so in liver transplantation specifically. And out of these 6 described methods, the number 3, 4, and 5, that is intermittent clamping, ischemic preconditioning of the liver, and increasing the duration of declamping during each cycle. These are the 3 methods that have been kind of studied very extensively amongst specifically in the western part of the world, where they have done numerous studies comparing different types of clamping methods and its implication on the post-operative clinical outcome as well as biochemical outcome. So as a hepatobiliary surgeon, you need to know the balance between ischemic damage to the liver vis-a-vis your amount of major blood loss in a major liver resection. And I think you should not be, you should be flexible as far as inflow occlusion is concerned. So, and one thing you must remember, the women liver has got too much of portosystemic collateral, so the liver can tolerate ischemia. But you should be applying this ischemia as and when it is required, and in my view, you should not be applying it presumptively. So there are so many types of vascular control that has been described. In the subsequent slides, I'll try to explain it in a diagrammatic manner for the benefit of the residents. So out of all these methods, this Pringle's maneuver, be it continuous or more specifically intermittent, it is the most time tested and best methods as of now. Though this sentence itself is debatable, but as of now, there are the highest number of papers. If you see the hepatic literature, it comes from the Pringle's maneuver only. So I'll just try to briefly try to show what does this vascular occlusion means. If you see the first diagram, it is a total vascular occlusion. That is, we are clamping the whole of the inflow of the liver, and we are clamping the infrahepatic cava and the top cava. This is the total vascular occlusion. In the second, we are not occluding the top cava. We are just occluding we are doing a Pringle and infrahepatic IVC clamping. This is mostly when Ganesh will be speaking next after me. We both worked together at ILBS for a year or so. But whenever the top end, the anesthesia you are not comfortable with and they are not able to keep a good CBP, then you can just do a Pringle and you can clamp the infrahepatic cava. In the third one, you can see that we are just clamping we are doing Pringle and we are individually clamping the hepatic veins so that we can maintain the caval flow. This is technically, though it is difficult, but this is a very, very well tolerated methods of clamping, and it is as good as doing only Pringle. And the last one is you can just preserve the portal flow by clamping the top cava below the joining point of the hepatic veins. So these are the different methods of clamping. And in total vascular occlusion, you can see you need to do the Pringle, that you need to clamp the inflow of the liver, and followed by the infrahepatic cava and followed by the suprahepatic cava. But this the total hepatic vascular exclusion, many patients may not physiologically tolerate it well because it is associated with 50% decrease in cardiac index. That may be too much in sicker patients or pediatric patients. So before that, you need to do a 5 minutes of preloading, preferably with 20% albumin or 5% albumin if it is available. And then you see the tolerability, and then only you can go for total hepatic vascular exclusion. And if the mean arterial pressure is the fall is more than less than 80 millimeter of mercury, then you declamp the cava, optimize go back to step 2, and then again try. Once before starting resection, if all these methods are sustainable, then only you go for you start for hepatic resections after doing a hepatic vascular exclusion. So coming to isolated clampings, I'll be speaking about mostly about this Pringle maneuver and hemihepatic occlusion. In hemihepatic occlusion, you can see you can either clamp the whole of the right Gleasonian pedicle, or you can clamp whole of the left Gleasonian pedicle. And in segmental occlusion, you can go for right posterior, right anterior. In right anterior also, you can separately clamp 5 and 8. In right posterior also, you can separately clamp 6 and 7, which I will be showing in one of the videos. So there are some areas which are not yet sorted out, but the first one is the continuous or intermittent Pringle. There are so many literature published, and it mostly depends upon the individual surgeon. Belgetti published way back in 1999, again in Annals of Surgery, and what the subsequent, there are so many literature published on intermittent versus continuous Pringle, and almost majority of them, I won't say all of them, but majority of this literature which are published on intermittent versus continuous Pringle, they tell that both are the same. You can do whatever you want. It all depends on the surgeon. Personally, I believe this intermittent Pringle is much, much better than a continuous Pringle, specifically in cirrhotic or compromised livers, in post-chemotherapy livers. Secondly, duration of intermittent Pringle. The standard is 15-5, 15-5, but there are some literature where they have compared 30 minutes versus 20 minutes, 20 minutes versus 15 minutes. So in JHEP, in 2011, they published on 15 minutes versus 30 minutes in a subgroup of patients having intermittent Pringle, and they also tell there is no difference between the two. As there is no difference, so the liver fatty acid binding protein, increase in liver fatty acid binding protein was the primary endpoint. So both the groups had same. So you can go for either of these. So it all depends on institution to institution. Total clamping duration. The maximum number of minutes for which you can clamp the inflow in a cirrhotic liver obviously differs and decreases as compared to a non-cirrhotic liver. In annals of surgery, I could find an interesting study again from Torgili. They do a lot of Pringle because in that part of the world they do ultrasound guided segmental or non-anatomical liver resections for colorectal liver mets, and they tell that for a normal liver or for a post chemotherapy liver also you can safely clamp the inflow for cumulative period of clamping of 120 minutes. So these are the and the last one is the ischemic preconditioning. Ischemic preconditioning is clamping the hepatic inflow for 10 minutes, release it for 10 minutes, and then you start your proper Pringle's maneuver. So in British Journal of Surgery, one RCT was published in 2011, where they have compared between ischemic preconditioning followed by intermittent Pringle versus intermittent Pringle alone, and the primary endpoint was again elevation of ALT on day one, and both the groups had same. So what I meant to say is that obviously there will be differences in opinion, but in my view, intermittent Pringle is always better, specifically for compromised livers. Ischemic preconditioning may be beneficial more, so there is no harm to it. You just precondition the liver and then apply proper Pringle. And out of the total duration, and it should be maximum up to 1 hour cumulative duration, and at a time it should be 15 minutes, 5 minutes. So whenever we are planning a major liver resections, this has been our departmental protocol for a long time now. So there are 4 areas we can actually plan the liver resections: the patient's factor, the tumor characteristics, the background liver, and the most important is the proper and legitimate assessment of the background portal hypertension. So I'll just show this is one of the patient where we just think in this way only in for all the major liver resections. And in this patient, as we can see, is a diabetic hypertension. These all will hamper liver regeneration. It's a big paracaval tumor and a child age cirrhosis with a FLR of 50%. So the plan was right hepatectomy straight away because it has got a good FLR with no clinically significant portal hypertension. And in all big paracaval tumors, it is always better to plan a total vascular exclusion and then do the surgery. This is the Marian volumetric images of the patient. You can see this is a large this is the tumoral area, and this is a large paracaval tumor sitting next to the IVC. So the exact thing was depicted in a pictorial diagram before the surgery, and I have a habit of drawing in selected cases that before the surgery, and our plan was to do a Pringle and top cava and bottom cava control after doing a volumetry on Marian, which was 50.1% of FLR. So this is a very short 1-minute video where this is a straightforward right hepatectomy. For the benefit of residents only, I have kept this video. After ligating the caudate branches of the right portal vein and taking out the peritoneum over the portal vein, the right portal vein is looped. Then this is the infrahepatic cava being looped. Infrahepatic cava being looped. In case there would be a need for total vascular isolation, this is the top cava. I'm trying to take control of the top cava. This was in the initial years, obviously it was way back in 2021. So the top cava is being looped. For all paracaval tumor, I think at the beginning of your career, it is better to take control of all the vessels. You take control of the right hepatic artery, cut it, followed by the right portal vein, and then you go for parenchymal transactions. This is not a typical Pringle, but this is a hemihepatic occlusion. So as you can see, the blood loss would be very minimal if you stay onto the demarcation line and if you follow the correct surgical principles with a good energy device, that is KUSA. So in the second patient, if you see the background liver is a grade 4 fibrosis. We do not do biopsy of the background liver, but this patient was referred from outside to our hospital. So compared to first patient where the liver was more or less normal, though in the first case also in final HPR it came out to be cirrhotic, bridging fibrosis was there. But in this patient, there was a big tumor sitting on predominantly on the right anterior sector, but there was some abutment to the right hepatic vein. So the plan was to do a right hepatectomy. 61-year, lot of comorbidities and background liver fibrosis. So in this kind of patients, taking a good hemihepatic control is very, very important. That will decide your surgical blood loss and outcome as well. So we at AIIMS Bhubneshwar, we have a very low threshold for volume augmentation. So in this particular patient, right portal vein as well as right hepatic vein embolization was done. And after achieving a good volume, this patient was planned for surgery. So I'll just show the inflow control part. I have edited accordingly. So in all the patients with right portal vein embolization, there would be some amount of hilar rotation. There would be some amount of caudate hypertrophy, and the glue used in right portal vein embolization will also hamper the resection. So the hepatic artery proper being looped, followed by the main portal vein, then the individual hepatic artery, right hepatic artery, the segment for or the middle hepatic artery, and then the portal vein, though it was not properly looped, you can just put a clamp and get a line of demarcation. You can encircle the portal vein later on once you have finished majority of the parenchymal transaction. This is the advantage of, and you like in this patient, the caudate lobe was also very big. So after caudate transaction only, you can get hold of the right portal vein in majority of the cases with right portal vein embolization. So after caudate transaction, ligating the right portal vein becomes very easy, and then you can go for a safe resection. So this is the third patient, which was a CA gallbladder neck with hilar infiltration. So we gave neoadjuvant chemotherapy, and simultaneously we did volume augmentation in terms of right portal vein embolization as well as right hepatic vein embolization, and then she was taken for a liver resection. So in this patient, you can see there was a lot of the exact part I have kept just because of in cases of hepatic vein embolization, you would get a lot of back bleed from the liver, specifically towards the segment 8, because the liver is congested as well because of right hepatic vein embolization. So in cases with right hepatic vein embolization, this hemihepatic occlusion may not help, and you may have to clamp the main portal vein as well as the hepatic artery in order to decrease the bleed. And in this particular scenario, this hemihepatic occlusion that may not help as well. I'll just there are some issues with the PPT. I'm just closing the PPT and we'll start it again. There are only 2 or 3 slides more left. I'll just
Yeah, no problem. We have time. In the meantime, Phani, what is your opinion about both that we have done a transarterial chemoembolization and right portal vein embolization? Is there
I
any
mean,
risk?
no, if there should be a gap between them, and the transarterial chemoembolization should be selective, because there is that concern that after portal vein embolization, the tumor growth is faster. So if there is the transarterial embolization is selective and there's a gap of minimum at least about 10 days till the liver enzymes were all normalized, then it's okay.
Okay.
Sir,
Yeah.
may I start now, sir?
Pattnaik, please continue.
Yes, sir. So there were a lot of back bleeds, specifically in the cranial part of the liver, because of the right hepatic vein embolization. So in this case, we this some of the video is not playing again.
If you have the separate video file, maybe you can open
Yes,
it.
yes, that I'll show, sir. I'm just.
And while you are loading it, are there any issues with double embolization, that is portal vein as well as hepatic vein? One you mentioned, liver gets congested. Is there any other problem?
LFT wise, we have not faced anything, sir, because at our center, this is very routine to do total vascular deprivation. We called it as a total venous deprivation. So
Okay.
one of my MCS student is also doing thesis, and she is looking at all the profiles post-operative LFTs and post-operative outcome, and there is absolutely no difference. It is perfectly safe. Like Phani sir said, it has to be on a the LFT should be monitored and there should be a gap. But once the LFT is normal, then we can very well go. Sir, is my screen visible now, sir?
Not yet.
Okay, sir.
And how much is the time gap between portal vein and hepatic vein, and which one do you do first?
First is a right portal vein, sir, and the gap, it all depends. Suppose our target is a FLR of 40% and the initial volume is just suppose it is just 19% per, let's say. So we won't be waiting for 3 to 4 weeks after right portal vein embolization. Rather, we would be doing total venous deprivation in the same admission itself. We'll do a right portal vein embolization, check the LFTs, and 5 to 7 days later, we'll be going for right hepatic vein. And suppose it is borderline, let's say it is 29% and our target is 40%, then we'll just do right portal vein embolization, wait for 3 to 4 weeks, and again reassess the.
But a minimum of 5 to 7 days gap between portal vein and hepatic vein embolization.
Yes, sir. Usually 5 to 7 days. What we follow here, the logistically also it suits us because the higher their day of cath lab and all that also comes into account. But it is never before 3 to 4 days in our practice.
Okay.
Sir,
So-
is my screen visible now, sir?
No.
We can see the screen. You open the video, please.
Okay, sir.
We can see the files folders.
Your screen is visible, of course.
Now the video is visible, sir.
Not yet.
Hmm.
Is it playing on your screen?
Yes, sir. I'll
No.
again open the. I'll skip this video and then go to the next slide. Now my slide is visible, sir.
No.
Your screen is visible, the folder you
I think you stop sharing and now we can see the.
So I'll just skip that slide, sir, because this was
Okay.
a patient where there were a lot of bleeding. So hemihepatic occlusion was not sufficient. So we went in for a Pringle for 10 to 15 minutes to take out the specimen. I'll now come to the next patient, who's got a huge SCC, relatively young patient, 30-year male patient, post TACE, and right extended hepatectomy was planned and right portal vein embolization was done. It was a very big right-sided tumor. The background liver was again cirrhotic. So in this kind of patient, large size tumor, what happens is that just outside the liver, that is, this is our transaction surface in Merian, and this is the tumor, and this will be our transaction surface. This will our line of transaction. So what happens is that, in my view, if the tumor is very large, the adjoining part of the liver, they are very much congested in terms of they are pushed towards the left lobe. And in these scenarios also, there will be a lot of oozing and bleeding even if in presence of low CVP. So in this type of specific scenarios also, this Pringle maneuver may help. Like you see, this we have already completed the parenchymal transaction, but towards the later part, there were too much of bleeding. So the right hepatic artery and right portal vein were already taken off, but as the bleeding was too much, it was mostly due to oozing, and after controlling CVP and everything, still it was oozing. So we went ahead and did applied clamp directly onto the right hepatic artery proper and main portal vein. And after that, as you can see, the field is very clear. Total clamping duration may be 2 Pringle episodes, like 10 minutes each, and you can safely do a surgery. So this is like Phani sir was asking during introduction as well, whether I'll be speaking about some segmental occlusions as well. This is a patient where it's got a segment 6 HCC, and fortunately the portal vein, the right posterior portal vein was supplying only to segment 6, and the segment 7 portal vein was draining into the right anterior portal. So this patient was taken off for surgery for isolated segment 6 resection, and this is just a minute video where I'll show. The video is relatively on 4x speed, I think. So this is the main portal vein being encircled, and we do intraoperative ultrasound in almost all cases of liver resection. And this is along Rouvier sulcus. I'm just doing a bit of hepatotomy to get a good length of the right portal vein, followed by the right anterior portal vein, and then right posterior portal vein, and the isolated branch to the segment 6. This is the isolated branch of the segment 6 portal vein, and once you ligate it, you can get a demarcation marking, and after that you can transact only the segment 6 of the liver. So this was the specimen. And lastly, in pediatric patients and in tumors, like sir was telling about central hepatectomy. In central hepatectomy, the challenge is to take a right anterior pedicle, and most of the time it has to be taken extrahepatically. But in cases where the tumor is sitting right on the hilum, like in this kid, this is a 10-month-old kid we operated 2 weeks back. So after 4 cycles of super Plado regimen for hepatoblastoma, got a good response, and then we took this kid for central hepatectomy. So in this type of cases, this is the tumor actually. So where the tumor is just sitting at the hilum, this is very difficult to kind of go and do some extra Gleasonian looping of the whole of the anterior pedicle. So in this type of scenarios, individual identification of the separate branches of the right anterior posterior artery and right anterior posterior portal vein is very crucial. The right anterior is taken off. This is not the main, this is the right portal vein, and followed by the right anterior portal vein will be looped. And once the right anterior portal vein is looped, we can get the line of demarcation, the right-sided line of demarcation. The left transaction surface is always very easy in central. So once we have demarcated the transaction, we can very well go up to the segment 5, the dorsal branch of the segment 5, V5 dorsal branch, and we can complete the transaction. This was a additional visceral vein in this patient. You can see this is the visceral vein. This is the segment 4 tributary of the visceral vein that can also be taken care of. No Pringle, nothing is required. If you are doing going on a good plane and you are selectively isolating the pedicle and clamping it, I think in pediatric patients, those hemodynamically they are very fragile, and we can avoid a Pringle. This is the taking down of the middle hepatic vein, and the only structure remains. We follow a pedicle last approach in all central hepatectomy, and what remains is a right anterior pedicle, and it can be taken down. So conclusion is that Pringle is, in my personal view, Pringle is very rarely required nowadays, specifically in anatomical resections. And most of the time you can get away with a hemihepatic occlusion. more so centers practicing live donor liver transplantation, where you cannot apply Pringle, or you can just Pringle during the while doing duct or so. So in those cases, the surgeon should be well trained for non-transplant resections and transplant resections in the same way, so that you can avoid Pringle, and it is actually not needed many of the time, but you should not play to your ego, and whenever it is required, you can better clamp it. I think these are the three scenarios where you can think of doing Pringle. One is non-anatomical resections. Due to lack of time, I could not show few of the big non-anatomical resections for hepatic hemangiomas and all, or in patients with hepatic venous deprivations, where there is a good amount of back bleed is there, especially on the cranial segments, you need to do Pringle. And in non-CUSA transactions, like I'm also a big fan of CUSA. We have hardly done any liver resections without CUSA. So if you are using CUSA, then there won't be any problem. But if you are doing other methods of transaction, or if you are trying to finish the liver transaction in a time-bound manner, then you may have to. I've seen people using Pringle even for radical cholecystectomy. Again, that is a non-anatomical resection, and if you want to finish it quickly, Pringle may help, but it should be used on an SOS basis and not on a routine basis. Thank you very much.
So before Phani starts the discussion, two questions, Pattnaik, I have. One, that in the case where you wanted to do an extended right, was it a classical extended right or a modified? Because you didn't embolize the segment 4 branch of the portal vein.
Sir, our protocol for embolizing the segment 4 is that if we are planning a right extended, we always embolize by ipsilateral approach. We puncture from the right side, our IR people, and they'll embolize the right as well as segment 4 in right extended in all cases. But in right modified extended,
yes,
like in CAGB, where we are preserving segment 4A, we do not embolize the segment 4.
Yeah.
But in this case, right as well as the segment 4 embolization was done.
So students, for the students, very important point that if you are planning a classical extended right, which means that you are taking the entire segment 4, then it is better that you embolize the segment 4 branch of the portal vein also. On the other hand, if you are doing any modification of extended right, which means you are removing only 4B, or you are taking only wedge of 4, which is possible if the indication for extended right is CAGB, and it is the pedicle involvement that is necessitating the right hepatectomy, then you need not, because then you want to preserve the blood supply, the portal venous blood supply of the remaining part of the segment 4. So that's very important. Second point, Pattnaik, now since your concluding slide, you say that it may not be required in all cases, but then at what stage do you recommend to a surgeon who's starting to do a liver resection that whether the entire pedicle or only hemipedicle, should one try to get at least a loop around in the beginning and use it as and when required, or should you go ahead with your resection and when bleeding occurs, then you go for it?
Sir, for non-transplant resections, like for tumors, it is always better to do a hemihepatic occlusion, get a demarcation line, and straight away ligate the right hepatic artery or left hepatic artery, or the individual hemihepatic artery and vein, because that is the advantage in non-transplant resections. But we need to loop everything, like I showed in two of the case scenarios, where even after ligating the right portal vein, and while doing a straightforward right hepatectomy also, there was too much of bleed. So we need to apply Pringle. But if at all we have a low threshold for Pringle, what happens is that, especially in the beginning of the career, if you are little amount of bleed and you have started using Pringle, then it becomes time bound. You keep on watching the clock when the 15 minutes will lapse, and you try to rush in, and then the major problem it starts. The bleeding may actually increase, and everything, the small ducts which needs to be clipped, they get missed, and you try to cauterize, and that lands up in a post-operative bile leak as well. So liver resections, this maximum 1 hour use of Pringle, that should be reserved, and it should be properly utilized, the resources, rather than very liberally using it, sir.
Anyway, Pringle during transplant is another topic in itself. We will not go into that debate. So, Phani, maybe 5 minutes comments on Pattnaik's presentation, and then we'll move on to Ganesh.
I think one important message for the residents is Pringles is a safe maneuver. Don't hesitate to use a Pringles. I mean, ischemia was bleeding. Ischemia is any day better than bleeding. And there is so much of data on Pringles that it is a safe maneuver during hepatectomy. You don't have to hesitate at all. For example, I mean, just going back into that area, but let's say when Pattnaik was stressing that in the non-transplant scenario, you can use non-transplant. In the living donor transplant, where you're worried about ischemia, even in that, if you have bleeding, studies have shown using with Pringles and without Pringles. You would imagine that's the area where you're worried about ischemia the most, because the liver, you're not going to take it out, you're going to put it back in another person. Even in that, the outcomes, the post-op enzyme bilirubin rises, they have not been much different using Pringles with no Pringles. So it's that safe. So one definite thing is Pringles is a safe maneuver, and there is no data showing that it's a detrimental in any way, especially in a healthy liver. Number two is with, like you're saying, with CUSA, you can use a Pringle. You could try without a Pringles, but with cheliclysis, if you're doing cheliclysis, whatever studies that show that cheliclysis is faster and less blood loss compared to CUSA, they're always with inflow occlusion. So cheliclysis for major hepatectomy, if you're doing, always do with inflow occlusion. And there are variations of Pringles. One is the portal vein alone Pringles. So the thought process being that the bile ducts ischemia, bile ducts are more sensitive to ischemia, and so that way the artery is kept patent and portal vein alone is clamped. And we have been using that in patients with suboptimal livers. But like in a lot of these vascular control measures, the literature just shows that the minor difference in transaminitis and lactates, no significant clinical benefit. But this is one way of doing it, that you can do a incomplete Pringle. That means do a portal vein alone Pringles. And one more thing I wanted to, this thing was about continuous versus intermittent. In practice, how we decide between continuous and intermittent is if it's the healthy liver and a minor resection, non-anatomical resection, which you're going to complete in less than 1 hour, less than half an hour, you would just go for a single one-time occlusion. But if you're in a major hepatectomy or a diseased liver, if you're planning more than 1 hour, always go for an intermittent Pringles. One more concept which we could have elaborated a bit more is ischemic preconditioning. Ischemic preconditioning is obviously short Pringles, which is done and before you start your intermittent inflow occlusion, about 5 minutes, to sort of to get the liver tuned to the the ischemia. There is a concept called remote ischemic preconditioning also. That means you do the preconditioning remotely. So before you start the surgery, 5 minutes this thing of the limb ischemia is induced by using a tourniquet or a balloon, this thing, and the 5 minutes of 5 cycles on and off, 5 cycles on and off, to bring about the same benefits which you do of ischemic preconditioning. But again, this shows only minor differences in transaminitis and lactates, no tangible clinical benefit. One more point I wanted to make is total vascular occlusion. We are always worried about how the patient will tolerate, and especially in the elderly patients with total vascular occlusion, it is the risk of renal failure and decreased urine output, cardiac events is there. So if you are a guy starting off on your first total vascular occlusion and you're in a multi-specialty hospital, rest of the world in the UK, US, most of the time, if it's a planned total vascular occlusion, you have the option of going for a veno-venous bypass. So you can do a veno-venous bypass between the femoral and axillary. That you use a routine bypass, the bypass machine which the cardiac surgeons use, and with that the entire venous return is returned to the heart, and you can actually do a safe. So when you have an emergency situation, you don't have a choice. But if it's a planned situation and you have the access, use a veno-venous bypass. There is one more variation. I mean, that was interesting. All the variations he showed, the bottom clamp alone. There is one more variation in Japanese. I don't remember the surgeon's name, but we have done that when you are working on the IVC. Like there was a tumor. He was saying the tumor has gone onto the IVC, but you're not sure. You might not require a total occlusion. partial infrahepatic occlusion is also there. So that you do a Pringles and a partial infrahepatic occlusion to reduce the pressures. Two questions for Brahmadat. I mean, the Brahmadat, I've had almost zero experience with hepatic venous occlusion. So could you again just tell us in simple terms what are indications was for right portal vein occlusion and right person was hepatic vein occlusion? And if you're doing it for a right hepatectomy, my concern was if you occlude the right hepatic vein, the flow to the MHV goes increases. I thought so. Do you have you noticed that when you try to preserve the MHV and you do a hepatic vein occlusion, is there increased bleeding in your experience? Because I've had no practical experience. That's one of my concerns.
Sir, in hepatic venous occlusion, we have a very non-flexible protocol of our minimum FLR for different clinical scenarios.
Okay.
If it is pediatric, 20% is okay. For
Okay.
adult, normal 30%. Any amount of fibrosis, any
Yeah.
cholestasis, like for CAGB, any prior history of chemotherapy, minimum is 40%.
Particles, yeah.
Suppose hepatitis B positive, but tumor looks, the background looks non-cirrhotic, then also 40%.
40%.
For child age cirrhosis, it is 50%.
Okay.
So on an average, what we have been doing, like I'm telling, we have been doing a thesis on this about the amount of liver regeneration after PV and HB and the functional regeneration as well, doing a hepatic scintigraphy. We are doing that now.
Yeah, I know.
So suppose our experience is that after portal and embolization, roughly 10 to 15% of the liver regeneration is usual. Suppose our target is 40 and the initial FLR is 20 or
Okay.
23. We will do it in the same sitting. First, right portal and embolization. Suppose Monday we are doing right portal and embolization. Next Monday we will be doing right hepatic vein embolization. And suppose it is a very close, like our target is 40, or suppose target is 50% in a cirrhotic liver, but we are doing the volume is 42%. Then we will just do a right portal and embolization, wait for 3 to 4 weeks, and then reassess. It all depends what is our target FLR is. And technical complications, we have operated a good number of patients after hepatic venous isolation. Specifically, the cranial segments, like between segment 5 and 8, the liver atrophy is too much compared to right hepatic vein alone in many of the cases. So the hilar rotation as well as the overall hypertrophy is too much compared to right hepatic vein alone. So in those cases, the dissection of the MHB, the individual branches of segment 5 and 8, that area there are too much of back bleed in few of the cases. So in those cases, we have clamped the hepatic artery or portal vein for 10 to 15 minutes. And we always leave a stump of 1 centimeter in the right hepatic vein, and so that we can clamp or put a vascular stapler so that
I will, sorry, I will interrupt.
Yes, sorry,
We need to move
sorry.
on because we are encroaching into Ganesh's time.
Sure.
So let me introduce the next and last speaker for the day, Dr. Ganesh Nimje, who's currently faculty member in the Department of Anesthesiology at AIIMS Gorakhpur. But till a few months ago, he was my colleague at Mahatma Gandhi Medical College and Hospital. And as a part of organ transplant anesthesia team, I can say with happiness and pride that he was one of the pillars of our liver transplant program. I thought that Ganesh can tell us about what is thromboelastography, because I feel that all surgical students, while they must know surgery, they should know a little bit about the related disciplines also. And in fact, I'm very seriously thinking of having a session purely on gadgets and appliances which we surgeons use during surgery. Everyone should know. So today, Ganesh is going to tell us about TEG. Ganesh, over to you.
Good evening, everyone. Thank you, sir, for the kind. Sir, how was that, sir?
We can't see you. We can hear you, but we are not able to see you.
Actually, I started the video, but it's not working here.
Okay, so you share your slides, share your presentation.
Okay, sir.
Yes.
Sir, my screen is visible.
No, it's a whiteboard.
Okay.
While Ganesh is sharing, all the students can give me a feedback whether they would like to have that session on gadgets and devices. Yes, now we can see it. Please start.
Sir, and video, sir?
No, we are not able to see you, but it's okay as long as we can hear you.
Yes, sir. But thank you, sir, for kind introduction and inviting me to this prestigious JST tutorial on the liver resection. So today I will discuss a thromboelastography with you, which commonly short form in called as a TAKE. So sir, 1 minute, sir. Actually,
Yes.
Sir, 1 minute.
I think if you click on the view, maybe it will at the left upper corner view. No, the other side, left.
No, that's for the slide. This thing is not for the whole screen board.
Okay.
This
So
is
if
okay.
you want to
I
continue
mean,
like
yeah.
this, it's okay. Yeah. Please continue like this only. It's okay. Yes. Yes, we can see it now.
Yes, sir. Thank you, sir, for your patience.
Yes.
So we have lots of coagulation tests like PT, INR, APTT, thrombin, tryme, platelet counts, fibrinogen assist, and D-dimer. Then, and on that basis, we manage the coagulopathy with the FFP, cryoprecipitate platelet, or with the help of tazobactam acid. Then why we need the another test? So let's find out. Move back to the basis. Basis is the coagulation pathway. As you know, when there is the injury to the any endothelium, the platelet is attached to the endothelium with the help of 1 milliband factor, and there is a flowing of platelet which result into the formation of the platelet plug. This is primary hemostasis, and the activation of the clotting factor occur after that. So the intrinsic and extrinsic pathway of coagulation is activated on the platelet. So it results into the activation of the factor 10A, which convert the prothrombin into the thrombin, and thrombin convert the fibrinogen into the fibrin. So fibrin polymerization occur on the platelet surface. So we get the good quality of clot. That is secondary hemostasis, and this is controlled by the various inhibitor of the coagulation. So this is a normal coagulation pathway. Our routinely tests like PT-INR, which tell us about only extrinsic pathway of the coagulation till the formation of the fibrin. And second test is APTT, which give idea about the intrinsic pathway of the coagulation till formation of the thrombin and fibrin. Next test like platelet count, which give the idea about the platelet count present in the blood, but it doesn't give any idea about the a contribution of the platelet in thrombus formation. Now next stage is D-dimer, which give idea about the fibrinolysis. And next stage is thrombin time, which give idea about the time to form thrombin in the blood. And last stage is fibrinogen, which give idea about the fibrinogen concentration in the blood. But it doesn't tell us about the contribution of the fibrinogen in clotting process. So these stages give idea about the some part of the coagulation system, and none of the give idea about the whole process of the coagulation, including the factor which inhibit the coagulation. And in liver disease, we know there is the rebalance hemostasis. That means the factor which promote the bleeding is counteracted by the factor which promote the thrombosis. So none of the routine tests give us idea about the whole process of the coagulation. That's why we need some advanced coagulation testing like thromboelastography and rotation thromboelastometry. So these are the point of care coagulation tests. So now move to the take. It take monitor the thrombodynamics status of the blood, as is measure the both viscoelastic and mechanical properties of developing clot. And it assess the all process of the coagulation pathway from single blood sample. Means from single blood sample and from single test, we know about idea about the whole process of the coagulation, starting from the clot initiation up to the lysis. So this is the take machine. The working principle is very simple. The pin is suspended by the torsion wire into the cup which rotate at angle of 4 degree 45 minutes. As the clotting process started, the fibrin get attached to the pin, and there are some motion in the pin which get detected by the transducer, and we get this type of graph. It looks very complicated, but for the interpretation, I will make it simple. It creates this type of graph which has a different value: R time, K time, angle, MA, and L/30. R means reaction time. It means the time to reach amplitude up to 2 mm. As we know, this is the coagulation pathway. During the initial pathway of the coagulation, intrinsic and extrinsic pathway activated. So it gets result into the some amount of the clot. So means if R, and this is extrinsic path, intrinsic and extrinsic pathway is correlated with the R times. Means if your R time is prolonged, means there is a problem with this coagulation factors. And K time means time to reach amplitude from 2 mm to 20 mm on take graph. And angle means the angle angle to the horizontal axis. The K time and the angle, it denote the kinetics of the clot, and kinetics of the clot is depend upon a function of the fibrinogen present in the blood. If K time is decreased, if the K time is prolonged or angle is decreased, means there is a problem with a fibrinogen in the blood. So if K time is prolonged or angle is decreased, then in patient, then we have to transfuse fibrinogen to the patient. The MA is the maximum amplitude. It, it, uh, denotes the maximum vertical beat on the graph. The L time is the time to reach amplitude of the clot. The L time is the time to reach amplitude of the clot. And K time is the time to reach amplitude of the clot. So the value of the MA is depend upon the platelet and fibrinogen present in the blood, active platelet and fibrinogen present in the blood. So if MA is decreased, means there is a deficiency of either platelet or fibrinogen in the blood. So we have to transfuse either fibrinogen or platelet to this patient. The lysis 30, LY 30 means lysis after formation after MA in this graph. The normal value of LY 30 means lysis at the 30 minutes is 7.5% and LY 30 means lysis at 60 minutes. The normal value is 7.5% and 15%. If there is more lysis happening in the blood, then we have to transfuse tranexamic acid to this patient. So from the single blood of sample, we know all the process of the coagulation. So this is the advantage of the take during management of the coagulopathy. There are some. So we get this type of graph after we run the sample. It has R time, K time, angle, MA, all written in this report. So on looking at this report, you can individualize the treatment for the patient. There are some modification of take, like kaolin take. In this, the kaolin act as a contact activator. There is called rapid take, means in which the tissue factor added to get the rapid result. In hep take, like S take, like in sometimes the patient is on heparin to prevent thrombosis. So in that space, the heparin is neutralized by adding heparinase in the sample, so we can assess the action of heparin in the blood. And there is another test for functional fibrinogen assess. So as we know, the maximum amplitude in the take is formed by the platelet and fibrinogen. So which if MA is decreased, then we are in dilemma whether to transpose fibrinogen to the patient or platelet to the patient. So in that case, functional fibrinogen testing can be used. In this test, the platelet inhibitor added to the blood sample, so that if platelet is the problem, then the graph is normal. If fibrinogen deficiency is present, then the graph get decreased. So by doing functional fibrinogen assay, we can get if patient required platelet or fibrinogen. So from the graph, we can give the FFP, like how fast the clotting process started. If R is prolonged, means the clotting process is very slow. Then in that case, we have to give FFP or PCT to the patient. How slow means how MA is, how the height of the graph is. If MA is too low, then we have to give either cryoprecipitate, either a cryoprecipitate or platelet, depending upon the functional fibrinogen assay and how long it lysis. If patient have lysis more than 7.5% and or 15%, we have to transfuse tranexamic acid to the patient. Now come to the Rotem. Rotem is another point of care coagulation testing. The working principle is simple. The pin is in intake, the pin is fixed, but in Rotem the pin is rotating. So blood is kept in a sample and the pin is rotating, so that if a blood clotting process started, the rotation of the pin is affected and it detected by the sensor, and we get this type of graph. In Rotem graph, we have CT means clotting time, CFT means clot formation time, angle alpha, maximum clot firmness, MCF, and we have lysis at 30 minutes. The take graph and the Rotem graph look nearly same. They have CT time in Rotem is correspond to R time in take. CFT time is Rotem is correspond to K time. Angle remains same. Maximum clot firmness in Rotem is correspond to MA. And lysis at 30 and 60 minutes same. The definition is same, and the interpretation is same. So in take, if RN CT is prolonged, in take RN CT in Rotem is prolonged, means the patient have a deficiency in a soluble protein factor. So in that case, we have to transfuse FFP or prothrombin complex to the patient. If K time or K time is prolonged or angle is decreased, then we have to transfuse a fibrinogen in the form of cryoprecipitated to the patient. If MA is decreased, either we have to transfuse fibrinogen or platelet to the patient. If lysis is more, then we have to transfuse antifibrinolytic to the patient. So these are the normal value. We don't need to remember it, because it come with the reports. So there are some modification in Rotem, like INTEM. INTEM detect the intrinsic pathway of the coagulation. EXTEM in Rotem, it let us know about the extrinsic pathway of the coagulation. In FIPTEM, we know about the contribution of the fibrinogen by adding antiplatelet in the blood. In APTEM, we know about the lysis present in the blood, and in HEPTEM, we know about the any contribution of the heparin present in the blood, like in heptec in take, which same as the heptem in Rotem. So it's a same rotation Rotem values. So from the Rotem, we have idea about how fast is clotting process happening. If CT is prolonged, then we have to give FFP or PCC. If MCF is low, then we have to give either cryoprecipitate or platelet, depending upon the FFP. And if lysis is more, then we have to give tranexamic acid to the patient. So these are the take in various coagulopathy state. This is the normal take. On second graph, the starting process, that is R time is prolonged. So it, because of the presence of the any anticoagulant or factor deficiency. On second graph, the MA is less, amplitude is less, so it may, because of the platelet deficiency. On fourth graph, we can see the lysis happening. So in that case, we have to give tranexamic acid to the patient. On a fifth graph, we can see the increased coagulation activity. That's called hypercoagulation state. On sixth graph, there are the lysis, but patient have hypercoagulable state. It's seen in DIC stage 1. In DIC stage 2, we get complete hypocoagulable graph. So these are the take in various coagulopathic state. So now move to this study. This study done in Tata Memorial Hospital on post-liver resection patient. They did the prospective intervention study. Means if the take value is hello?
Yeah, we can hear you.
Hello.
I think, Ganesh, your signal is probably weak. In between, your voice is breaking.
Yes, sir. Sir.
Yeah. Okay. Please carry on. Please carry on.
Yes, sir. So they did study on 25 patients, and they got 16 patients are hypocoagulable. So they transfuse blood when they see hypocoagulability on routine coagulation test and on the basis of take.
I think there is some internet issue at Ganesh's end.
Yeah.
Hello, sir. I'm audible.
Yes.
Yeah,
Now we can hear you. Yes. Please carry on.
Sir, they measured the routine coagulation test at a pre-op, intra-op, 6 hours after shifting to ICU, then at a 48 hour and on day 5. They see the on day 1 and day 2, though the patient is hypocoagulable on the basis of INR, they have normal take in majority of the patients, and if INR is more than 1.5 and take show the abnormal value, then only they transfuse the blood products. So they concluded that the in INR always overestimate the coagulopathy in patient undergoing major liver resection, and the take guided transfusion strategy reduce overall blood transfusion requirement. And there is another study done at ILBS on donor hematotomy patient, and they did routine coagulation test in a preoperative period, intraoperative period, 6 hours after surgery, day 1, day 2, day 3, day 5, and day 10. Also, they did take simultaneously. So they found the patient is hypocoagulable at day 1, day 2, day 3, and the normal coagulable at day 5 and day 10. But in take, the patient is hypercoagulable at day 1, day 2, day 3, and day 5. They said that though the PT-INR value is on higher side, but on take, the patient is on hypercoagulable state. Means chances of the thrombosis are there. So they concluded that the after liver resection, hypercoagulability is very common, and take should perform to know the correct nature of the changes of in coagulation following donor hepatectomy. Also, one systemic review show that on take or rotem, only 4.6% patients are hypocoagulable, but on routine coagulation test, 65.8% patients are hypocoagulable. So the blood transfusion during the post-operative period not depend upon the value of the PT-INR only. There is another review, systemic review done in liver transplant surgery and during elective cardiac surgery. They concluded that the take-guided blood transfusion therapy is needed to decrease the blood transfusion rate and loss of bleeding rate and mortality in patients. So now come with the example. If 40-year-old male patient posted with the right extended hepatectomy and blood loss is around 1.5 liter, and after that there is a oozing from the raw surface of the liver, or there is post of blood in vein, and we get this type of graph on the take. In this graph, the R time is slightly raised. Angle, the K time is very low. The angle is 40.5, and there is very increased lysis present in the blood. Lysis is around 37%. Means this patient need tranexamic acid, at least 15 mg per kg bolus dose, followed by 5 mg per kg per hour infusion. This patient doesn't need fresh flotation plasma FFP. This patient need antifibrinolytic agent. This is a second patient in which the R time is prolonged, K time is also prolonged, angle decrease, MA is also decreased, and lysis is okay. This patient need fresh frozen plasma and cryo precipitate. This is normal take. I conclude that take and rotem provide an idea about the whole process of the coagulation. We do the individualize the treatment for the coagulopathy management, and the great advantage is that we can see the response to the therapy also by repeating the take, and it reduces the blood transfusion requirement, and it also helps in deciding when to stop and restart the anticoagulant if a coagulopathy develop perioperatively. Thank you.
Thank you, Ganesh. We are already beyond 9, so Phani, just any 1 or 2 minute comments before I close the session.
Yes, sir. I mean, see, it was an excellent lecture, Ganesh. I think you comprehensively covered everything. Tech is very important for for all surgeons to know, but we always have the anesthetists to interpret for us. More importantly, I want one message for all the residents and people who are starting in their career. You have to understand this concept of rebalance hemostasis, that your INR and platelets, the basics PT, APT, would not reflect the actual coagulation status. People think that is relevant only in the transplant scenario, but it's actually equally relevant or even more relevant in the non-transplant scenario also. For example, a cirrhotic you're taking up for surgery is INR is 1.5, platelets are 50. Doesn't mean you keep on giving FFP and platelets, because actually they could be procoagulant. Likewise, during a hepatectomy, you're having a lot of bleeding. It could be due to venous congestion. You think that it's due to, if you blindly give FFP, you're actually further overloading the patient. So even in the non-transplant scenario, whenever you have this kind of a dilemma, if you have the facility available, one is understand the concept. Don't blindly correct the PT, INR, platelets. It could be detrimental. And also, if you have the access to tech, use it in all these scenarios.
Okay, so we are beyond 9. We have a tradition that we start in time and finish in time. So I would like to thank Dr. Phani Krishna Ravula for agreeing to moderate this session. And in fact, he does liver surgery very regularly, and he's done various types of liver resections. Maybe one of these master classes, we will have the video presentations by some of these experts. I would like to thank the three speakers, Krishna, Ganesh, and Pattnaik. As I mentioned, the JST and all its activities are being managed by my colleague, Dr. Anand Nagar, and all the technical support for live transmission, for video recording, for uploading these videos is being provided by my former fellow and consultant GI surgeon in Ahmedabad, Dr. Avinash Tak, Dwarika Hospital, and his team.
Thank you, sir.
And so this is the information that how those who are still not members of GST, please send a WhatsApp message to Dr. Anand Nagar at this number, and then you will receive information about all these activities. So, Phani, can we close the session then?
Thank you, sir.
Thank you. Thank
Thanks
you.
to all the
everyone.
speakers.
Thank you so much, sir. Thank you, sir.
Good night.
Thank you so much, sir. Good night.